The heartbeat depends on a finely tuned electrical system where every impulse is precisely coordinated. When that rhythm is disrupted, the consequences can be life-threatening. That's where antiarrhythmic drugs come in. To understand how antiarrhythmic drugs work, we first need a framework. Most antiarrhythmic drugs are organised using the von Williams classification, introduced in the early 1970s. This system groups drugs according to their primary effect on the cardiac action potential. It's important to remember that many drugs don't fit neatly into a single class, but the von Williams system remains a useful starting point. Class 1 drugs block sodium channels, slowing the rapid upstroke of the action potential and reducing conduction. Class 2 drugs are beta blockers. Rather than acting directly on ion channels, they reduce sympathetic influences on the heart. Class 4 drugs block L-type calcium channels and primarily affect the atrioventricular node. Class 3 drugs are different. They mainly act by blocking potassium channels, prolonging repolarization and increasing the effective refractory period. Because repolarization is governed by multiple potassium currents, understanding class 3 drugs requires a deeper look at cardiac potassium channels. This plot shows a typical action potential recorded from cardiac ventricular muscle. Class 3 antiarrhythmic drugs act during phase 3 of the cardiac action potential, the phase responsible for repolarization. A full explanation of all phases of cardiac action potentials is covered in a separate video, which you may want to review if you're less familiar with the underlying electrophysiology. In this lecture, we'll focus on how potassium currents shape repolarization during phase 3. Repolarization is often described as if it were driven by a single potassium current. In reality, it results from several distinct currents, each with different kinetics and physiological roles. The main currents involved are IKr, IKs, and IK1. The italic I denotes current, K indicates potassium, and the remaining letters specify the subtype of current. R stands for rapid, S for slow, and 1 refers to the inwardly rectifying potassium current, which stabilizes the resting membrane potential and contributes to the terminal phase of repolarization. Among the potassium currents involved in repolarization, 2 are especially important for understanding class 3 antiarrhythmic drugs: the rapid and slow delayed rectifier potassium currents, known as IKr and IKs. IKr is carried by the hERG potassium channel, encoded by the KCNH2 gene. Mutations in this gene cause congenital long QT syndrome type 2. I've covered the structure, drug sensitivity, and unique properties of the hERG channel in detail in a separate video, so I won't repeat that here. When activated by depolarization, ion channels transition from a closed state to an open, then an inactivated state, where they remain open but cannot conduct ions. IKr activates relatively rapidly, but undergoes marked inactivation during depolarization, which is even more rapid. As the membrane repolarizes, this inactivation is quickly relieved, and channels remain open for a significant time before closing. allowing IKr to contribute strongly to phase 3 repolarisation. The second current, IKs, is the slow delayed rectifier potassium current. IKs is conducted by a channel complex formed by KCNQ1 and its regulatory subunit KCNE1. Mutations in the genes encoding these proteins cause long QT syndrome type 1, which often presents during exercise or emotional stress. IKs activates more slowly and shows little inactivation. Its contribution becomes more important at faster heart rates, when the cell spends proportionally more time depolarized, and during sympathetic stimulation, where it helps shorten the action potential. Let's now see what this looks like during the ventricular action potential, starting with IKr. Although IKr activates rapidly with depolarization, much of the current is immediately inactivated, so its contribution during phases 1 and 2 are relatively limited. As the membrane potential begins to fall during phase 3, this inactivation is relieved. IKr then increases sharply and contributes strongly to early repolarization. This makes IKr a major determinant of the timing and slope of phase 3 at normal heart rates. Blocking IKr therefore produces a pronounced prolongation of the action potential and the effective refractory period. For that reason, IKr blockade can be highly effective as an antiarrhythmic strategy, but it also carries a significant risk if repolarization is prolonged excessively. Now compare this with the slow delayed rectifier current, IKs. IKs activates much more slowly and shows little inactivation. During a single action potential at resting heart rates, its contribution is modest early on. However, as depolarization is prolonged or occurs repeatedly, IKs continues to build and contributes increasingly to repolarization, particularly later in phase 3. At faster heart rates or during sympathetic stimulation, IKs becomes much more prominent, helping shorten the action potential and preserve normal rate adaptation. In this way, IKs acts as a protective, rate-dependent reserve rather than a dominant baseline current. The effect of blocking IKs therefore depends on the heart rate. At normal rates, blocking IKs has little effect, with repolarization largely preserved by IKr. In contrast, during tachycardia, whether due to an arrhythmia or sympathetic stimulation, blocking IKs impairs action potential shortening, abolishes normal rate adaptation, and leads to progressive prolongation of repolarization. Here we can now put those effects together on the action potential itself. On the left, you can see the effect of blocking IKr. Even at a normal heart rate, repolarization is delayed. Phase 3 becomes shallower, the action potential is prolonged, and refractoriness is increased. On the right, blocking IKs looks quite different. At resting heart rates, the action potential changes very little because repolarization is largely maintained by IKr. The difference becomes apparent as heart rate increases or sympathetic tone rises. Under these conditions, the action potential normally shortens, but it fails to occur when IKs is blocked. With repeated depolarizations, repolarization progressively lengthens, reflecting loss of repolarization reserve. So, although both interventions prolong repolarization, they do so in distinct ways. IKr blockade produces a prominent effect at baseline, whereas IKs blockade primarily reveals itself when the heart is stressed. This visual difference underlies the very different clinical profiles of drugs that target these currents, which we'll turn to next. So far, we've focused on the delayed rectifier currents, but there is one more potassium current that plays a crucial supporting role, the inwardly rectifying potassium current, IK1. IK1 is most active at negative membrane potentials and is the dominant current maintaining the resting membrane potential in ventricular muscle. During depolarization and the plateau phase of the action potential, IK1 decreases and contributes very little, because inward rectification limits potassium efflux at positive voltages. As the membrane repolarizes and becomes more negative, IK1 re-emerges and contributes to the terminal phase of repolarization, helping to return the membrane potential rapidly and stably to its resting level. In this way, IK1 acts as a stabilizing current. It does not determine the timing of phase 3 in the way IKr or IKs do, but it ensures that repolarization is completed and that the resting membrane potential is firmly maintained. The role of IK1 is to complete repolarization and stabilize the membrane, while IKr and IKs determine how long repolarization takes. Class 3 antiarrhythmic drugs all act by delaying repolarization, but their clinical effects and risks differ markedly. To understand why, we need to look at how repolarization is shared between multiple potassium currents and how drugs interact with that system. Repolarization of the ventricular action potential is not the responsibility of a single potassium current. Instead, it emerges from the combined activity of several potassium currents, primarily IKr, IKs, and IK1, each contributing at different voltages and at different times during the action potential. Together, these currents ensure that repolarization is normally reliable and stable. Because their contributions overlap, repolarization has built-in redundancy. If one current is partially reduced by an antiarrhythmic drug, others may compensate, so the action potential may lengthen only modestly. This redundancy is referred to as repolarization reserve. Problems arise when repolarization reserve is already limited, whether due to genetic variation, structural heart disease, electrolyte imbalance, or conditions such as tachycardia or sympathetic stimulation that place greater demands on repolarizing currents. In this setting, additional potassium channel blockade by antiarrhythmic drugs produces a disproportionate prolongation of the action potential. Excessive prolongation of repolarization increases the likelihood of early after depolarizations, which can act as triggers for torsade de pointes. In this way, it is not potassium channel blockade alone that determines antiarrhythmic safety, but how a given drug interacts with repolarization reserve. With repolarization reserve in mind, we can now begin to understand why class 3 antiarrhythmic drugs differ so markedly in both efficacy and safety. Some drugs, such as dofetilide, predominantly block IKr and substantially reduce repolarization reserve. As a result, they cause pronounced action potential prolongation, even at resting heart rates. This underlies their antiarrhythmic efficacy, but also increases susceptibility to proarrhythmic effects, particularly torsade de pointes. Other drugs, most notably amiodarone, block multiple potassium currents, including IKr and IKs, with additional weaker effects on other repolarizing currents. By distributing the repolarizing load across several pathways, these drugs tend to preserve repolarization reserve. The resulting action potential prolongation is often more moderate and more stable across a range of physiological conditions, which helps explain the lower incidence of torsade compared with selective IKr blockers. In addition, some class 3 drugs have important non-potassium channel actions that further influence their electrophysiological profile. Amiodarone, for example, also blocks sodium and calcium channels and antagonizes beta-adrenergic receptors. These combined effects suppress early after depolarizations, slow conduction, and reduce re-entry, contributing to its effectiveness against both atrial and ventricular arrhythmias. However, beta-adrenergic blockade and rate-slowing effects seen with amiodarone and sotalol can themselves become proarrhythmic in certain settings, particularly when bradycardia further prolongs repolarization. Finally, ibutilide illustrates that individual drugs may have additional actions that modify risk. Although primarily an IKr blocker, it also enhances inward sodium current, which can paradoxically promote early after depolarizations under some conditions. So, while these drugs are grouped together because they delay repolarization, it is their interaction with repolarization reserve and with other ionic currents that ultimately determines both their clinical usefulness and their risks. Whether a class 3 antiarrhythmic drug produces a beneficial prolongation of refractoriness or a dangerous proarrhythmic effect depends not only on the drug itself, but also on the context in which it is used. Factors that reduce repolarization reserve increase vulnerability to excessive action potential prolongation. Bradycardia is one such factor because many repolarizing currents, particularly IKs, contribute less effectively at slower heart rates. As a result, blockade of IKr in the setting of bradycardia produces disproportionate action potential prolongation. Electrolyte disturbances, especially hypokalemia and hypomagnesemia, further impair potassium currents and amplify the effects of class 3 drugs. Genetic variation in ion channel function can also reduce baseline repolarization reserve, explaining why some individuals are particularly sensitive to potassium channel blockade. Drug interactions are another major contributor. Combining class 3 agents with other action potential prolonging drugs or inhibitors of drug metabolism can markedly increase exposure and further reduce repolarization reserve. Finally, structural heart disease and myocardial ischemia alter the balance of ionic currents and reduce the heart's ability to tolerate repolarization delay. In practice, Proarrhythmia arises when a drug that delays repolarization is applied in a setting where repolarization reserve is already compromised. In clinical practice, class 3 antiarrhythmic drugs are used to prolong refractoriness and suppress reentrant arrhythmias, but they are chosen with careful attention to both mechanism and context. Drugs that predominantly block IKr, such as dofetilide or ibutilide, are highly effective, but operate close to the limits of repolarization reserve. As a result, their use is typically restricted to carefully selected patients and monitored settings. Sotalol combines IKr blockade with beta-adrenergic antagonism. This can enhance antiarrhythmic efficacy by reducing sympathetic drive, but also introduces rate-dependent effects that may increase risk in the setting of bradycardia. Amiodarone occupies a distinct position. Although it prolongs the action potential and QT interval, its multi-channel actions distribute repolarizing load and suppress early after depolarizations. This helps explain why it is effective against a wide range of atrial and ventricular arrhythmias, while carrying a comparatively low risk of torsade de pointes. Ultimately, the clinical use of class 3 antiarrhythmics reflects a balance between efficacy and safety, determined not simply by drug class, but by how each drug interacts with repolarization reserve and with the patient's underlying physiology. To summarise, class 3 antiarrhythmic drugs all prolong repolarization, but they are not interchangeable. The potassium currents IKr, IKs and IK1 each play distinct physiological roles. It's the balance between these currents and the resulting repolarization reserve that determines both antiarrhythmic efficacy and proarrhythmic risk. Action potential prolongation alone does not predict proarrhythmia. Context matters.